I'd like to bottle that joy effect.
I sell it to you.
Yeah, all right, I'm taking it. I think we're starting to hear, I think, in each one of these witness and stories is really how complicated the networks of trust, the networks of influence, how detailed and granular this work is when you're really talking about that beautiful and exquisite intersection of community and healthcare. So I'd like to open up the floor for questions now. Here we go.
Hello. Okay. Bob McClellan, Dartmouth. The stories that you tell, each of you tell, are very moving. And there are also dollars associated with them. And one of the big challenges has been to collect those dollars and reinvest them in the right things. And so I'm just curious as to what happened to all those dollars that you saved, the health system or insurer, payer, et cetera, et cetera. You got some money back, a grant, $1,500, $5,000, but there's millions of dollars here to be saved that could be reinvested in doing the right thing. So what happened to the dollars?
Well, for the Methodist system, I can say that it looks like we were saving the system a lot of money, but we were actually saving the payers a lot of money. And so at my exit, we went into a cost savings agreement with Blue Care Medicare, because right after Amber, they sent me a Jessica. Same scenario, except for she had Blue Cross commercial. And we kind of saved them maybe $600,000. So they entered into a cost savings. And so I can't wait to hear how that pans out. Now, the dollars that you saw at the end helped me migrate into the position that I'm in now. So Florida is a little more different, right? And so we're going in saying, this is what happened in Memphis. It's not as complex here. So can we start off with the good faith and you give us collateral up front to help keep your patients out of the hospital?
I just echo really what Joyce said, but I think it's looking at different payers. I think the critical thing with the 38109 work was that Cigna was very excited to be in that work because they were saving money. And it turned out that actually 38109 had the highest overutilization of the ED of a lot of its payers. It was a big payer in that area. It was close, but it was a big one. Mm-hmm. And so they were very invested in trying to put that money back in. So I think looking at different stakeholders in terms of where the money flows is a really important thing. And I think those stories that Joy tells, and they're case studies, and people can poke holes in them all day long, and they will. But I think the other thing that we didn't say was, like in Amber's case and many people's cases, their suffering was ameliorated. Right. Her whole quality of life improved so much more. And really, that's what we're in the business for, right? It's great to save dollars, and it's great to reinvest. I would say that most health systems are still a little bit on the fence and trying to figure out how to do that in a real strategic way. I think they want to. Most of the leaders kind of have a desire to do it. But a lot of times it really is predicated on what's the margin this year? Okay, we've got a good margin. Well, we'll do a little more investment. But even that's not particularly strategic. I think we're moving into a space where we'll do more of that. But most health systems, I don't really think, are in that business yet of truly reinvesting. Gary, of course, can come up and talk about his proactive mercy versus reactive charity. So he's been preaching to that choir for a very long time. But I think we'll keep preaching that. And I think stories, the mixed methods, the case studies, the stories, the narratives, which faith and community do very well, and then the data, particularly the dollar signs, and combining those, I think is a very powerful narrative and speaks to many different stakeholders. So I think you have to kind of do it all at one time. Anybody else want to?
I guess I know it's hard for Brandon to step in and his team to step into that question, but the question is, if there's dollars that come out, the opportunity for reinvestment, how do those in reinvestment possibly go to faith-based providers or people who are doing this walking with, the 14 week stay, the 40-week stay, and how, what does that case management look like so that it increases both the data and successful, we're tracking the health outcomes in relationship to the hospital. What does that case management partnership look like, and how could dollars, whether they're community benefit, expenditures, reinvestment of savings, I don't know if that's something that we can address in this conversation, but when Brandon was talking about the length of stay, in my mind was saying, well, what is the needle shifting on which conditions they have, and how are we tracking those conditions, and I know that you are in the midst of talking to ERs now about how to be more present at the moment when someone presents in a situation of an overdose, and how do you move them to the right treatment facility, and then how does that case get managed and followed, right? So,
I don't have any answers. I would say that if you look at addressing the social determinants of health, or the community-based navigators, or the work that Brandon and his team do, the actual cost of running that program compared to a clinical program where you've got a nurse, you've got a doc, or you've got a whole crew of clinically based folks, is always you're going to get a better return on investment just because of the sheer pay scale of someone who's working as a navigator or working in a faith-based or a community-based program. And Brandon, come up and speak to that. I'm sure you can share more about that.
It's a great question. The cost for many of the agencies that we partner with are significantly less than a clinical situation. And in many cases, we're actually more qualified to meet some of the extenuating circumstances that have contributed to the initial presenting problem in the emergency room, or the legal system, or the political system. You name the system that our clients are engaged in. And so I love the discussion between prevention and reaction. Unfortunately, we often fall into the last case scenario. These are individuals who have already burned all their bridges. They've expended their health insurance benefits. Their families are now bankrupt. And so, of course, naturally, we do partner with businesses and corporations, and we would hope that because of the work similar to what these ladies are doing, that some of these foundations would be able to pour back into evidence-based and efficacious programs instead of bad money chasing the same problem over and over again. So, but it's great to, now's the time that these organizations should be having that conversation, because those dollars will disappear if we don't tell them where to go.
Can I say one more thing to the point? The way the reimbursement structure for Medicare alone, I know we sometimes think we're just going around the city or going around in circles. We're positioning ourselves because hospital systems are going to have to invest in population health. They're going to have to do it. And the drivers of that is the faith-based programs, period and point blank, because they have the trust. Your churches, your mom and pop faith, your FQHCs that are faith-based, they have the trust. And so as this new pay structure rolls out, it's going to put more dollars on the ground. So I would rather have infrastructure ready and waiting than have to recreate something that could actually fail once we get it up and running. Does that make sense?
Yeah. Got a question in the back. I'm Chad Walker with Transitions Life Care. We're one of the largest hospice providers here in the state of North Carolina. And I just had a question with the studies of where you said you were creating more access to home health and hospice care through your program. What did you see as like the real turning point? Because a lot of times there's a lot of misconceptions around hospice care, stigmas, and there's also kind of the different hierarchy of needs from food, nutrition. So hospice kind of gets toward the end. So how were you able to bring people upstream to access that earlier?
That's a great question. With regard to home health, I'll remember a particular incident. Our chief medical officer at downtown Methodist University, Robin Wamadou, who's a wonderful internist and a great person, good friend, helped educate us a little bit when we were talking to some folks in the congregation, because she said, part of the reason that people will not sign up for home health are because they live in that 38109 neighborhood. They're older and frail. They're afraid to go to the door and open the door for a stranger. And so what we began implementing was having folks from the congregations go meet that person once they got out of the hospital, when that nurse was supposed to come or whatever case manager was coming for that immediate initial visit for admission. And it bumped the rates up tremendously, right? That one little thing, by listening and acting upon it in a way that was value added for people in the community. Per hospice, I would say that part of what we did, and I didn't get a chance to mention this, but part of the Machine and Congregational Health Network was these wonderful adult education venues that we did for 7 weeks. I think there are 14, maybe more, different trainings that were done. We never paid anyone to actually lead the trainings. They were very adult education focused. They were very black church focused. We would end by holding hands and praying. 75 people holding hands and praying at the end of these 2-hour meetings. But they began the process of that. We actually had hospice staff come and teach the end-of-life care. And through that process, people in community began trusting those providers, so that when they needed hospice, they would say, we know that doc. He was so kind and he answered my questions. He's a good man, and I'm going to put Mama in hospice. And so I think it was really that relational aspect of building trust via the education that was really what people needed. And we never taught any class without asking people in the congregations, what do you want to learn? We didn't come and say, we've got a grant in diabetes education. We said, what do you want to learn? And we crafted the learning and the educational venues in the curriculum based on what they wanted. The only formal one we did was mental health first aid. The rest we just created. So that's a good example of listen, you ask, you listen, you do something about it. That begins to build and hold trust. And I think that's what happened with the hospice in Memphis. I'm very proud of that, though, by the way.
I have to mirror those comments, not with hospice, but for mental health care. High correlation in our populations between substance abuse disorder and homelessness and mental health. And so no one trusts me enough on day one to accept my referral to someone who can help. They may accept a sandwich or a hot meal or a cold drink. It's over time that you build those relationships, and that's how we expand our access and our care into people's lives that otherwise just would not. They don't trust the system, and they can only trust what they can hold. So,
Heidi, I have a question for Brandon. Sorry. 3 more minutes. So if he makes it quick. Brandon, you mentioned that you've formed a lot of partnerships over the years, and I was wondering if you could say a little bit about your partnership with UAB School of Nursing, and then the health center that is now running that program.
Absolutely. I mentioned, at the Foundry, we're not a clinical location. We don't diagnose, we don't prescribe, we don't treat, but we do care. And it's kind of ironic. A number of years ago, the Alabama Department of Mental Health actually tried to either shut down or take over all of the faith-based recovery programs in the state. And we joined together and formed an organization called the Alabama Association of Christian Recovery Ministries. And out of that, we realized that we're stronger together than apart. But at the same time, we were reaching out to those clinicians, to those professionals who could provide the very services that the state of Alabama was wanting more people to have access to. And so instead of it being a relationship, an adversarial relationship, we turned it to be an advantage. It showed that we were miles apart. When we're almost at the point where our lawyers are talking with each other instead of us talking to each other. And we have turned those relationships from bad to good because we're willing to sit down and talk about it. But this University of Alabama in Birmingham's School of Nursing, Dr. Selleck and her team have done an excellent job. and providing community-based health care in the Bessemer area, in others, but specifically the Bessemer area, to where literally I have a health clinic across the street from my office. I can't throw very well, but I can throw a rock and hit this clinic. And so it's very easy to access basic health care on day one. If we identify someone who's in a high-risk targeted area, HIV, hepatitis C, or a chronic illness that we find in intake, we can begin to address that immediately. Because the last thing we want to do is invest this amount of time, effort, and resources into someone, and they have to leave us because of an existing medical issue. And so it serves them, it serves us, it serves our purposes. But in addition to the clinic across the street, we have partnered with another agency in town, the Alethea House, who's also the largest nonprofit housing provider in our state. Again, it's a continuum of care that was built by this executive director, and he went after the federal dollars to open a federally qualified center, which also happened to just be right around the corner from my office. And so instead of competing with one another, we all three sat down and said, okay, how can we do this better? And we are doing it better. Whereas before our clients, it was costing us $10 to $15 a piece. Well, now it's not costing them anything. And they have more staff, they have more equipment, they have a better location. And so because we didn't look at each other as competitors, we looked at each other as collaborators and maybe even instigators from time to time, instigating change. We're able to do more than we were. In addition to that, this UAB School of Nursing, I have a free medical clinic once a month for Birmingham's homeless community. It's never charged a single thing. The most common participants, and I know our time's out, is blood pressure medicine, cholesterol medicine, diabetes care. They are going to come alongside us. Instead of once a month, starting in May, we are going to have a clinic every Tuesday night where we target an individual health need that otherwise would not be targeted in Birmingham. So the UAB has been a godsend to the Foundry and the people we serve. I could give 20 other collaborations today. 20 minutes was not nearly enough time to share just how vital it is for us to do what we do well. So thank you for your time.
Before I thank our guests, unless you guys wanted to say one more thing. Thank our presenters today. I want to make a quick note about faith-based recovery and for money that is coming out now from the state, from the 21st Century Cures Act, for instance. It looks like that now you can read the funds that will be going into states for substance use treatment and recovery. Some of those funds can be used indirectly from the state in the form of a voucher, so that someone can elect to avail themselves of faith-based recovery services. So a group that may not consider themselves eligible for federal funds, they may not be eligible for direct funds, but they could be eligible for indirect funds. And we'll look at this budget as it comes through and the enormous amount of money that will be coming out through the 21st Century Cures Act. So there are opportunities oftentimes for faith-based providers to participate in those funds that they may not have been aware of, and part of our job is to get that word out. I want to thank our guests. What a riveting and important conversation. Thank you all.